Okay, it's 7 o'clock. Let's go ahead and get things underway. I'm Andy Meacham. I'm introducing folks this morning. Dr. Schulich is out of town. First presentation is going to be given by our good friend, my good friend, Arek Wiktor. And Arek is Associate Professor of Surgery. You're like, he's your friend, how come you're looking at your phone? Because much of that like I don't have all the details in mind. He's the director of the University of Colorado Burn and Frostbite Center, the program director for the Surgical Critical Care Fellowship with Burn Focus. He went to University of Colorado School of Medicine, completed a surgery residency here, did a fellowship in burn surgery, and then a University of Michigan Critical Care Fellowship. And I think everybody realizes the burn program here has just done an outstanding job. Dr. Wiktor has been really responsible for bringing it to the exceptional status that it's in now. Arek, excellent job. The title of your presentation is I Wore White Pants Today, Medical and Surgical Management of Complex Hidradenitis Suppurativa. I'm not going to venture an exact interpretation of the white pants piece, but I guess we'll get to the seat of the problem.
Yep.
There you go.
Thank you. All right, let's get warmed up and talk about some awesome things like hidradenitis. So my name is Arek Wiktor. I'm the director of the Burn and Frostbite Center. Thank you for the opportunity to present today. And I'll talk about something a little bit different than what you're used to hearing from me about burns and frostbite, and specifically about hidradenitis, which is a disease that has a lot of parallels with burn in terms of the care management and why probably I've grown a soft part for this. The only disclosure is that I'm a consultant for Avita Medical, but there's no relevant issues with this. So I'll talk about a case, and then we'll talk about the pathophysiology of HS, the medical therapy, the surgical therapy, show some complex cases that we've done in the burn center, and then some future plans. So this all kind of began about 5 years ago on one fateful day when we were consulted by the medical service for a 44-year-old female who had been suffering from long-standing HS for about a decade. She was admitted to the medicine service, had a lot of consultations, and their only solution was, unfortunately, there's not much to be done. She just needs to go home with some pain meds. She had been on and off biologic therapy for about 5 years, had intralesional Kenalog injections, and as a last resort, they consulted the burn team. So these were some of the most profound necrotic HS lesions that I'd ever seen. She had total atrophy of the subcutaneous tissue underneath. And what I didn't quite understand then, which I understand now, is it wasn't necessarily due to the biologics. It was that this was just an end stage portion of her disease with probably too much intralesional Kenalog causing significant atrophy in these planes. You could literally stick a finger up underneath all of the skin and just dissect her entire skin off with a finger. So you can imagine her quality of life was terrible. Her HS began 10 years prior when she had her son, and she had been suffering with this for a long period of time. So we took her onto the burn service and began basically an 87-day journey where we took her off all of her immunosuppression. She was on steroids as well, did a lot of excision, wound vacuuming, and then we did grafting, et cetera, of all the areas. And I think we achieved some pretty good outcomes. And so when she came to clinic the first time after her 87-day length of stay, she was beaming, really happy, and I thought it was just because she was, not inpatient anymore in the hospital. I said, "Why are you so happy?" And she said, "I wore white pants today." And she hadn't worn white pants in a decade because of all the drainage, and I thought that was very significant. And so that's why I decided to label the talk today. So HS was first described in 1839. And it's a complex disease of the apocrine glands, basically causing inflammation, which I'll get into the pathophysiology and forming these nodules, abscesses, and tracts. And you can see that there's a variety of these based on the severity of HS. It's not particularly common. The incidence is 0.1%. And it's actually more common in women, more common in people of color, and it's actually very common in Down syndrome, a 5 times incidence. And so I think the pediatric folks have a lot more experience with this on their side than on our side. In fact, it's recommended to screen for this disease younger in the preteen and teenage years, because that's usually when it kind of rears its head. And smokers also have an increased incidence because of the pro-inflammatory effect. In terms of comorbidities, it's usually associated with a lot of comorbidities as well: metabolic syndrome, obesity, PCOS, IBD, inflammatory diseases, thyroid disease, cardiovascular disease, anemia of chronic disease due to the inflammation, as well as vitamin deficiencies. So these patients have, in general, a very decreased quality of life, especially patients with early stage 2, 3, or more advanced disease. A lot of them have unemployment issues. Majority of them have depression issues and pain issues. There's a 2 times increase in substance abuse and 2 times increase in suicide risk. There's a lot of embarrassment from the odor, shame, isolation, self-consciousness, and I have some examples of this. So these patients are a needy patient population, and unfortunately, this is the HS Foundation website, which is a patient and research group for hidradenitis, kind of a national organization. And you can see in the center there, in the West, there really aren't any resources, or there weren't any resources in the past for these patients. And even when there are, diagnosis is troublesome. So the average time it takes for an HS patient to get diagnosed is approximately 7 years. And they've gone through 5 different types of physicians, as well as had at least 3 to 4 different diagnoses. So early on, it's actually very difficult to recognize HS, because people might think it's just a simple nodule or a draining sebaceous cyst, et cetera, and not until it forms its structural changes do people recognize, this is HS. And by then, it's a little bit, honestly, too late. So people get hidradenitis in a lot of the areas where you have the apocrine glands, as well as areas of friction. So you'll see it under the breast and the axilla, back, as well as back of the ear and the scalp, the groin, etc., buttocks. There's many different kinds of lesions that have been described, so inflammatory nodules. And you can see that this is kind of like the beginning of the disease. It kind of looks just like a small abscess, but it's really not. And then that progresses into potentially abscesses and sinus tracts, comiodomes, where you see these little blackheads that kind of go down, as well as significant scarring and plaques. And if you have these anatomic changes, this is exactly where the diagnosis of HS really kind of comes into play. There are many HS classification systems, but we'll really kind of just talk about the Hurley stages. So the Hurley stages, on its simplest form, are you have 1, 2, and 3 based on disease severity. So stage 1 is basically you have something that does not cause any anatomical changes to the skin area. So for instance, if you just had a nodule that went away or spontaneously drained, there would be a Hurley stage 1. The moment you start developing abscesses, tracts, fistulas, basically anatomic changes of the disease, it becomes a Hurley stage 2. In a Hurley stage 2, the difference between that and a stage 3 is there's actually normal skin in between those anatomic lesions in a 2 versus a 3. You can see it's just confluent. The whole skin area is affected by those. So let's talk a little bit about the pilosebaceous apocrine unit. And this is the cause of the disease and where the dysfunction lies. So in patients with HS, they basically have this follicular hyperkeratosis, which means that the hair follicle gets plugged abnormally. Normal folks that don't have HS don't have this issue. This causes a rupture of the hair follicle, and this pathway that feeds on itself, where you have increasing inflammation with TNF alpha, IL-17, et cetera. And I'll show more pictures of that. And instead of self-regulating itself and going away, this just kind of builds and builds until there's large tracts and sinuses that form and cause these structural changes. And that's the key to managing this disease, is trying to get it at the source before it becomes a structural issue. So here's a nice graphic representation of that. And you can kind of see on the left, you have a hair follicle with inflammation. Then you have the follicular keratosis, where you have this keratin plug. It becomes dilated. You start to have, again, inflammatory cells. The hair follicle then ruptures. And instead, you have this inflammatory milieu underneath. And then these will all connect together, and all the different hair follicles, and form these sinus tracts underneath, which eventually come up to the surface. Okay. An easy way that I like to think about this is like a prairie dog colony. So you'll see, some of the prairie dog little burrows on the surface, but you don't realize how extensive it is underneath. And the issue with HS surgery is you can remove, let's say, what you see on the top. Let's say the top of that burrow if you do a surgery, but that doesn't necessarily mean that you're getting all of those little tracts underneath. And your excisions have to be very wide and extensive in order to remove all of that. And despite removing all of that, just remember, this is a fundamental biologic issue with the patient's skin and the apocrine glands. So even though you may have removed all of the disease portion, even the normal skin that isn't affected can still get affected. So another way to kind of think about this, and I think this is the key to understanding this disease process, is the pathogenesis is very dynamic. It starts as an inflammatory disorder and turns into a structural disorder. And when it becomes a structural disorder, no amount of medical therapy is going to control it. No amount of medical therapy is going to rein it in. And this is where the surgical options come into play. You'll see in future slides that the paradigm shift of treatment of HS is trying to prevent it from becoming the structural disorder. If you can get the medications, immunosuppression on board before those changes happen, patients will probably have a lot better outcomes. Other factors adding to the pathogenesis, so not only from this apocrine inflammation, but you have friction from the areas of, let's say, the groin, the axilla, et cetera. Inflammatory cytokines from concomitant medical diseases. Genetic factors that can run in families as well. Hormonal, especially with women, it can be associated with menses, puberty, et cetera. Smoking, nicotine causes oxidative stress, follicular occlusion, as well as diet. Some patients will report definitely triggers in their diet, either due to dairy, brewer's yeast, bread products, milk products, et cetera. Nightshade vegetables, which are tomatoes, potatoes, peppers. Sometimes even eating those things can trigger a flare in a patient with HS. So this is a more deeper biologic dive. I'm not going to get into this, but recognize that the pathophysiology, the molecular pathophysiology is complicated. And these are the targets for molecular therapy for HS. And there's been a lot of advancements of this in the last 5 years, which we'll get into. And finally, there's actually a dysbiosis of these lesions as well. Patients will have biofilms with different species of bacteria, and this can sometimes correlate with their gut microbiome. And so there's a lot of this which has come out in the HS space, which we're seeing in other inflammatory diseases. So the optimal HS treatment paradigm, I would say, is a combined approach between medical and surgical therapy. You can't just have one without the other, because they really truly complement themselves in this disease process. And so you have dermatologists who are basically the front line, and the Society of Dermatology has put out a lot of really good papers about this, and a lot of dermatologists will manage some of these things in their clinic. They also manage the immunosuppression, as well as the other medical providers, internists, family practice, et cetera. And then you have the surgical side, So basically, almost all the surgical specialties at one point or another can be consulted, even colorectal, when these abscesses and tracts can get really close to the perianal area. So the principle, which has been kind of changed over the last, I say, 5 years because of the biologics, is again, for stage 1 to 3, optimize medical therapy to try to prevent progression of this anatomic disease. If there is this anatomic disease, you want to try to excise it and get control of it to try to get those patients back to a more stable skin function. And finally, if they're on biologics, we continue those throughout the perioperative period. And that's something that I didn't realize until I started getting into this. So weight loss, smoking cessation, again, what I mentioned before, diet issues as well as supplements, zinc, copper, vitamin D. You want to take zinc and copper together because they can inhibit each other's uptake. What do patients wash themselves with when they have these wounds? Well, this pyrothene zinc, which I'm pronouncing, I'm sure, poorly, has had some really good evidence in the literature, and you can buy a bar of this for $6 to $8 on Amazon. Or CHG bath. Some people use dilute bleach as well, and this is just to kind of help clean the skin, et cetera, on a daily basis. People will do Epsom salt, bleach baths, et cetera. Some people will use turmeric, apple cider vinegar, tea tree oil, et cetera. There really isn't some evidence for this, but I do think that washing it with the zinc versus the CHG helps a lot. When patients have wounds, we want to, again, maintain a reasonable amount of moisture. We don't want to have dry wounds where there's more friction and more inflammation. I'm not a sponsor of this, but I do think this is pretty amazing that there's a company out there called HydraWear, where they have these custom-made shirts and pants, et cetera, that have these slots and pockets where you can actually put ABD pads, et cetera, that will absorb the drainage but allow also ventilation, which is, I think, one of the biggest challenges for patients to manage on an outpatient basis. How do you secure the dressings, et cetera, to your axilla and your groin? In terms of therapy, you can see here that the medical therapy is on a continuum from early stage 1, 2, and 3, and the surgical therapy as well. So I'm going to break this down into something a little bit more palatable. Medical optimization starts by putting people on a bunch of medicines, actually, that you would potentially not be thinking of. So for instance, metabolic therapy, people are actually put on metformin, even though they don't have diabetes, because it's an anti-inflammatory. GLP-1 inhibitors, like Ozempic, have also been shown to decrease inflammation, potentially improve outcomes in HS. Hormonal therapy, like spironolactone as well, and finasteride are also mainstays. So you can see here that this is just the core base of taking care of HS patients. Laser hair removal, et cetera, treating their pain, all can kind of be part of that baseline medical pathway. Antibiotic therapy has also been prescribed. This is typically as a bridge to longer-term biologic therapy. If you see a patient with HS in the emergency department, they're not on any antibiotics, you can certainly put them on doxycycline and give them a 90-day prescription. Not only it helps with the bacterial overgrowth, it doesn't have much resistance, but it really helps with the inflammation. Again, these are bridges for flares and onto more long-term sustainable therapies. Long-term IV ertapenem has also been shown, which is actually very controversial because you have to put in a PICC line. Someone has to come to the hospital for 6 weeks or an infusion center to get this, but actually this has also shown improved outcomes in HS. So there are 3 FDA-approved biologics for HS. Before it used to be Humira, but now there's Cosentyx as well as Bimzelx. These are IL-17 monoclonal antibody inhibitors that just came out. And so what has happened in the HS, in this inflammatory kind of skin space, is there's a lot more therapeutic options for this. The clinical response rate, though, isn't what we would consider superb. It's about 50% at 12 weeks. And so patients will start on one, and if that doesn't work, they'll switch to another. But at least there are options. there are no head-to-head trials between any of these medicines. There's also been a lot of reports about off-label biologic in HS, which I won't get into, with varying response rates. The issues with any of these, again, we don't manage this, but just so you know, there's a lot of insurance issues. There could be latent viral issues, and they can have a loss of response. Either the body actually develops antibodies to the antibodies, or it starts to clear the antibodies faster, making them less effective. But again, it's very important to understand that it's safe to continue these during the perioperative period, both before, during, and after surgery. They're not going to increase complication rates. There's a lot of trials ongoing now in this space, and so this is actually something that's very new and kind of up and coming, which is great. What about surgical therapy? So we've kind of gone over the basic medical therapy, and you can kind of see why it's important to have a dermatologic or medicine colleague kind of help with this, because we don't have the resources, nor are we knowledgeable all the way in all those medicines. So the surgical guidelines in this document are, I would say, sparse at best. And that's because there really aren't any good studies recommending which types of surgeries are best for your patients. And you can kind of see here in this box, it says wound healing following surgery could be through secondary tension, primary closure, delayed primary closure, flaps, grafts, and skid substitutes. Okay, that's basically everything that we do. But is there one that's better? Is there one that we should go for? And the answer is we don't know. So there's a lot of unanswered questions. There's a wide range of techniques. There's people in this room I know of operate on HS. I know plastic surgery has excellent outcomes with their flaps. You can do VY advancement flaps. You can do perforator flaps. You can do rotational flaps. You can also do various types of grafts. But again, I think it really does depend on the patient needs and your experience and what they want. Patient satisfaction after surgery is actually very good. But because, again, this is a fundamentally a biologic disease that becomes a structural one, we have to accept certain levels of recurrence. There were two meta-analyses in the literature, one about 15 years ago, one about 5 years ago. And you can kind of see that the recurrence rates for, let's say, local excisions are about 20%. And more recently, wide local excision has a recurrence rate of 5%. But that's because you take it wide and you remove all of the tissue. So if we look at some specific little examples, if a patient comes to the emergency department, you see them in clinic and they have a little nodule on the left versus they have an abscess on the right, the therapy is going to be dramatically different. So if they have an inflammatory nodule, what is recommended is they actually get that nodule injected with triamcinolone, aka Kenalog. We do this all the time on our hypertrophic and keloid burn scars, and the typical dose of 20 to 40 milligrams per mil. You basically take a TB syringe with a luer lock, you stick it in the nodule and squirt in the Kenalog, and it actually decreases the inflammation substantially, and patients have a lot of relief after a few days. And that's really what they're looking for, is relief for those flares. Now, on an abscess, we don't want to be treating these abscesses similar to how we treat other abscesses, because if we just cut it open, A, we're not addressing the fundamental issue with the disease process. B, we're not actually removing any of those tracks, those prairie dog tracks. And so what's actually recommended is you just do a punch biopsy, an 8mm punch biopsy, just to relieve the pus, and that's it. Because again, you're not affecting structurally the disease. You're trying to give the patient relief of pain, which is probably why they're coming to the emergency department in the first place. De-roofing, this has also been described, also done in clinic, also done in the operating room. You can take a lacrimal duct probe, you can find the sinus tract, you can cut down onto it. Inside you'll find this like gelatinous goo, which I don't know if there's a scientific name for this, and you scrape it out. And it will close by secondary intention, as you can see on the right. But again, the issue is you're not addressing any of those tracks from the side, which is why it has a recurrence rate. Sometimes patients will say, I always have this spot right here that flares up. Well, you can try to cut that out, and you can see I cut it out, and there's a deep tract on the inside. But their recurrence rate is also high, sometimes 22 to 30%. And finally, you can just put a big whack on them. You can remove all of the tissue. So if you're having a hard time seeing, there's a penis there in the center, 2 testicles, as well as all of the groin, buttock, and abdomen excised. And so this is where I've partnered with Dr. Higuchi to kind of do some of these larger surgeries on patients that have such bad structural disease that's beyond, again, any kind of medical or local therapy. So again, what do you do when a patient comes in like this? Again, no medical therapy will fix this. This is now a structural problem that we need to remove and start from scratch. And there are very few actual case series of this in the literature. But I did find this for the urologist, which I think was pretty cool. They have this like scale for adult acquired buried penis scale, and it goes into all of the different ways that this can happen. And these patients, male patients with HS in the groin, can get this lymphedema that basically occludes some of the lymphatic channels from the scrotum as well as on the pannus, and they'll get this. This patient was dealing with this for 7 years. He couldn't hold a job in person, so he worked remotely on the computer. He was once stopped at DIA, and the security screener thought that he had a bomb in his scrotum. They did a medical exam on him just on the side because they didn't believe that this was actually part of him. And this is how profound this disease can kind of change people. And again, it's an anatomic issue. So how do we take care of this? Well, we took him to the operating room and did this in stages, removed his lower pannus and mons first because that was clearly infected. Then we went from a top-down approach and exposed both testicles and the penis. And then I did a near full-thickness graft, 1-to-1 mesh on the testicles, as well as a 2-to-1 and 3-to-1 mesh on his thighs and his abdomen, before and after. This is how he looked 2 months post-op and then 4.5 years post-op. So I think he had a pretty reasonable result given where he was before. He also underwent numerous laser therapies and Kenalog injections for scarring. Here's another patient, again, such bad, severe disease, out of control, not medically managed, full of tracts. This, again, needs, unfortunately, just complete removal of all of the affected tissues. And then we did grafting. What about perianal disease? Well, in the burn center, we almost never divert patients. We treat them with FMS, fecal management systems, and we still end up having, I think, pretty good graft take. But we do have our complications. These wounds are dirty. They're inflammatory. We'll have failure of allografts. We'll have failure of some of the dermal substitutes. So in a small little case series that I went through, on average, we have more males than females, an average age of 35 years. It's been, on average, 6 years of diagnosis before they end up seeing us in the burn center. 75% of these patients were on medicines. They usually stay in the hospital for an average 42 days and have 4 surgeries. And majority of them will have some sort of complication, either with bleeding or infection. So in summary, keep in mind that HS, this is, again, a metabolic disease, biologic disease that becomes a structural problem. What we want to do is optimize medical therapy before it becomes this issue. But once it becomes a structural issue, that's, again, where our goals are either to alleviate pain, do a small little abscess, IND, or Kenalog injection, or if you have to remove those tracts. So Dr. Emily Gorell, who I've partnered with in dermatology, have now become on the HS website, and now Colorado is on the map as a state for HS therapy. We have a case conference that we hold every month. If you're interested in participating, would love to have you come to that. We want to develop some pathways and protocols for care and obviously do some better research in this. So I want to thank the burn team, Dr. Tai Higuchi in urology, as well as Dr. Emily Gorell from dermatology. Thank you.
Thank you very much, Dr. Wiktor. I've got time for one question before we move on to our next presentation. And Arek, I will ask, this is an incredibly complex condition. And I think we're uniquely positioned here because you've developed such a strong multidisciplinary team. And by the way, Dr. Wiktor in 22 received the Medical Staff Leadership Award primarily for many reasons, but one of them was managing this condition. How many centers in the country really can bring this many resources to bear? I mean, I don't mean numerically, but it seems like many of these patients would be sort of getting piecemeal care at places where people just throw up their hands and say, I don't want to do what to do next.
That's a great question. The question was, how many centers can provide this comprehensive level of care? And I don't know, but I know from the burn world, there's like 4 or 5 burn centers where some of the burn centers attendings are really into this disease. So it's not many, I would say. We are going to do a review of the National Burn Registry to see how many burn centers participate in HS, but that's another good question. Like, I don't think many medical centers have the resources, especially dermatology. I think that's the rate limiting step. A lot of even the Denver metro area hospitals have all the kinds of medical specialties, but they don't actually have dermatologists. And I think that's one of the keys to treating this disease.
Great. Thank you very much for the presentation and the excellent work you're doing.
Thank you.
Thank you. Our next speaker this morning is Dr. Jonathan Hills-Dunlap, and he comes to us from the world of pediatric surgery. Dr. Hills-Dunlap did his medical training, received his doctorate in medicine from Stanford University. General surgery residency was completed in Brigham and Women's Hospital and Harvard Medical School, where he also received a Master's of Public Health. He completed his fellowship in pediatric surgery here at the University of Colorado. Very well done. And is now will be finishing this summer, a surgical clinical outcomes research fellowship with SCORE and the Accords program, and is really going to discuss what I think is I think most all of us feel is a very relevant issue. And I'm guessing, Jonathan, that when you started your fellowship, you probably didn't anticipate how many dramatic changes would take place in the course of the fellowship on a national basis. So I think the questions that you've been addressing are becoming yet more acute and probably more, I think they say, dynamic when things are unpredictable. So really looking forward to your presentation, and thank you for being with us this morning. Excellent. Pleasure.
Okay, thank you, Dr. Meacham, for that very kind introduction, and good morning to everyone. Thanks for the privilege of speaking with you today. So I have no disclosures. I fully recognize that health disparities in pediatric surgery are not directly applicable to the majority of the work being done by this audience in this building. However, I hope you'll bear with me as I... Oh, sure. Either one. Okay. Can you guys hear me? That sounds a little better. Yeah. Okay. So I hope you'll bear with me as I start with some background about why I think health disparities and health equity research are necessary, and to Dr. Meacham's point, even more necessary now than ever. We'll then review some key definitions in this space, discuss some of my own research, and then conclude with some take-home points given the very uncertain times that we're living in. So although difficult to imagine with everything else currently going on in the world, it's been exactly 5 years since our lives were turned upside down by the COVID-19 pandemic. At a rapid fire pace, if your social media and news platforms were anything like mine, articles like these ones were coming at you at rapid fire pace, highlighting these disparities and equities issues that I'm about to address. In the city of Boston, where I was training at the time, the objective data could not have been more clear. For those of you who know Boston, it's a city of neighborhoods, similar to Denver. And in Boston's Black and brown neighborhoods, rates of COVID-19 were markedly higher than in Boston's white neighborhoods. Black and brown communities across the country face stark inequities, both in testing and in vaccine access. And thanks to Dr. Schulich and Dr. Washington, this department had the great privilege of hearing from Dr. Ayla Stanford a few weeks ago and her tremendous efforts to combat COVID-19 disparities in her hometown in Philadelphia. In Boston at the time, objective data from the early vaccination program clearly demonstrated that equity was an afterthought, with nearly 700,000 residents vaccinated in the first couple of months in 2021. Only 3% of residents who were vaccinated were Black and less than 4% were Hispanic. But as you might expect, those percentages do not correspond to the overall rates of Black and Hispanic residents living in Boston. So let's focus just for a second on the Black community. On screen left, you can see that individuals who identify as Black make up approximately 22% of Boston's population. Yet the data on screen right showed that 33% of deaths were among Black residents. And again, only 3% of all fully vaccinated residents were Black at that time. So yes, 44% of all deaths had occurred in white residents, but 44% of Boston's population is white. And nearly half of those white residents were vaccinated at this time. Similar stories were unfolding across the country, including in Colorado. I came across this article from the Colorado Sun from August 2020, and they reported that Black and Hispanic Coloradans were disproportionately more likely to be hospitalized due to COVID-19 than their white counterparts. And I imagine many of you in this room saw the effects of that. This hospitalization data is another example of how historical inequities negatively impact health outcomes, is what Dr. Jill Ryan was quoted in this article, who is the executive director of the Colorado Department of Public Health. So my hope in sharing this information with you and repeating some of what Dr. Stanford shared with us a few weeks ago is to highlight how necessary health disparities and equity-related initiatives are. We are participants in a healthcare system and a larger society that, whether intentionally or not, favors certain people over others. And ignoring these issues or pretending like they don't exist doesn't mean that they don't exist. And certainly that certain populations are absolutely more likely to experience worse health outcomes because of the color of their skin or the language that they speak. But fortunately, in my opinion, as surgeons, researchers, and advocates, we are in a powerful position to do something about these health disparities. And this is especially true if you believe Dr. Stanford when she told us that closer to 50% of one's overall health outcomes can be attributed to what we do as physicians inside the walls of our hospital. I clearly have an immense amount of respect for Dr. Stanford, and she's been teaching me from afar for many years now. This is a picture I took at one of our largest pediatric surgery meetings back in May of 2022, where she was a keynote speaker. And she implored the audience to ask this question: how do I dispel a subjective narrative with objective data? And these words have become part of the foundation of my early research career. As I transition into some of my own work, I think it's important to explicitly define some key terms so that when we read or use these terms, we're doing so correctly and intentionally. First, the word disparities is defined by many sources as the condition or fact of being unequal. This word is often used interchangeably with words like different or differences. However, health disparities are more than just differences in health. Health disparities are a very particular health difference that can be linked with economic, social, or environmental disadvantage. And the disadvantage here is the key. Sometimes we use the term surgical disparities in our world, which means differential surgical access, care, and outcomes, owing to factors such as race, ethnicity, or socioeconomic factors. So importantly, not all health differences are health disparities. Now, what about health equity? During our recent HEAL Foundations courses over the past year, health equity was defined as the principle underlying a commitment to reduce and ultimately eliminate health disparities. But equity does not imply and should not be confused with equality. Equality would be a situation where every individual has the same resource allocation, the same bicycle in the example on the left, or the same crate in the baseball cartoon on the right. But in an equitable situation, each individual has the same ability to ride that bicycle or watch the baseball game because of intentional differential resource allocation. So a take-home point for me here, equity is not the same as equality. As Dr. Schulich told us a few weeks ago, despite the very interesting times that we're currently living in, we are still absolutely in charge of taking care of the people of Colorado and the mountain region. And in my opinion, we do that by ensuring that disparities are resolved, as shown on the left schematic, or at least remain unchanged in the middle as we navigate these interesting times. The third alternative on the right, where disparities worsen, to me, and I think hopefully to you in this room, is simply unacceptable. But there's a very real scenario that this occurs for many of our patients. So with all of that in mind, I'll transition to some of my own work that seeks to identify and ultimately eliminate health disparities amongst pediatric surgery patients and their families. And I hope that we would all agree in this room that kids deserve the highest quality of care and that in no way, shape, or form should they be treated differently because of the color of their skin, what language their parents speak, or any other social, economic, or environmental disadvantage that they may have. But it probably won't surprise you that health disparities exist in kids. Of course they do. And here are several examples from the pediatrics literature that describe these health disparities. So in adolescents with appendicitis, 40% of the variation in perforation rates can be explained by insurance status or income differences. In children with undescended testes, race, insurance status, and the hospital in which surgery is performed is associated with significant variation in the timing of orchidopexy. In trauma patients, children with public insurance or no insurance have been shown to have higher mortality rates. And finally, perforated appendicitis disproportionately affects minority race and publicly insured children. Through a series of studies and advocacy efforts, my own research career started out by trying to gain a better understanding of the practice variation associated with elective umbilical hernia repair in children. The goal was to improve guideline compliance for children who we discovered were at risk for potentially unnecessary surgery. And for the trainees in the room, I'd just like to emphasize here, this was my first foray into research. And I'd like to emphasize that despite the ups and downs of research, research can be extremely gratifying when you follow your passion and have one study question lead to another and another, and eventually, hopefully, into positive change for lots of patients. So why would a budding pediatric surgeon decide to study umbilical hernias when most aspiring pediatric surgeons are studying congenital diaphragmatic hernia or necrotizing enterocolitis or pediatric liver tumors? For me, it was all about having the greatest impact, the most number of patients. So umbilical hernia is one of the most common surgical conditions in children, affecting nearly 20% or approximately 800,000 children annually in the US alone. But fortunately, and this is for your ABSITE and future boards, this was actually on my general surgery boards, the majority of umbilical hernias will spontaneously close in the first few years of life and very rarely cause complications such as intestinal incarceration. And secondly, although robust population-based data were lacking to support these claims, previous recommendations from the American College of Surgeons, the American Pediatric Surgical Association, up-to-date and published systematic reviews suggested delaying repair of asymptomatic umbilical hernias until at least 4 or 5 years of age. So the fact that this pretty clear cutoff that we all learned in medical school exists made studying this pediatric disease fairly unique. So a review of the literature led us to ask a fairly straightforward initial study question, which was, do pediatric surgeons follow age-specific recommendations for the management of asymptomatic umbilical hernia? And for the next several slides, I'm going to use two key definitions. So if you're spacing out, this is actually important. Otherwise, you won't know what I'm talking about for the next few slides. So we categorize patients as having an early umbilical hernia repair, early, if they underwent surgical repair at 3 years of age or younger. So 0, 1, 2, or 3. We also categorize children as having emergent or urgent repairs if cases were associated with ICD or CPD codes associated with severe disease, or if surgery was performed during the same admission or within 2 weeks of an ED visit. The goal of this latter, somewhat confusing categorization was to also capture children who are undergoing early repair that may have been indicated, but where administrative codes would fail us. And here's what we found. Using the FIS database, we included nearly 25,000 children over a 5-year period receiving care at the major freestanding children's hospitals across the United States, including our very own Colorado Children's. You can see that children underwent early repair at every age, but over 30% of repairs took place in children who were 3 years of age or younger. These are repairs that potentially shouldn't be happening. The majority of cases were elective, and less than 4% of repairs were categorized as emergent or urgent, which you would think would be indicated at whatever the age. So when we analyze these data by individual hospitals represented along the x-axis, and I'm proud to say Colorado Children's is closer to this side of the graph, we identified an 8-fold variation in rates of early repair across these major freestanding children's hospitals. These rates range from 7% in Hospital 1 to almost 55% in Hospital 38. Again, what that means is 55% of repairs at that hospital are happening at ages 0, 1, 2, or 3. The blue squares represent the hospital level rates of emergent and urgent repair, which you can see do not correlate with the hospital level rates of early repair. So what's going on here? We hypothesized that some of the variation might be explained by differences in patient characteristics. Are these hospitals serving different patients? But after adjusting for all of the usual suspects, sex, race, ethnicity, insurance type, income, medical comorbidities, and emergent or urgent presentations, we observed an even higher 9-fold variation now in the rates of hospital level observed to expected ratios for early repair. So this variation that we observed prompted another study question. How much of this variation is due to surgeon level variation within the hospitals? Is Dr. Dave Partridge on one side of the spectrum, or is everyone doing the same thing at that hospital? So again, using the FIS database, we were able to calculate the rates of early repair for 322 individual pediatric surgeons at 37 major children's hospitals in this country. Several of these dots are surgeons that I now call my partners. Only surgeons who performed more than 25 cases over the 5-year study period were included. So new faculty like myself were not in there. In this figure, individual surgeons are represented along the x-axis, and you can see that rates of early repair ranged from 0% to 75%. When we analyze these data by individual hospital now, we observe some very compelling findings. Each box on the x-axis now represents a single hospital's surgeon level data. Variable lengths of boxes and whiskers suggest wide variation in surgeon level rates of early repair within their own hospital. For many surgeons, the overall hospital rate of early repair may not reflect their individual rate of early repair. So for example, in this hospital, one surgeon has an early repair rate of only 8% down towards the bottom, while their overall rate is over 40%. From these studies, we concluded that significant variation exists in the rates of early repair across the major freestanding children's hospitals in the US. Furthermore, provider level variation within hospitals suggests that surgeons within the same department or division may have highly variable management practices. These findings raise the possibility that many children may be undergoing potentially unnecessary repairs of their asymptomatic umbilical hernias that would otherwise close spontaneously with further observation. So this possibility prompted our next question, which aimed to look for health disparities. Do certain children, as compared to others, have higher risk of undergoing early, potentially unnecessary umbilical hernia repair? So just take a minute and think to yourself, which kid is more likely to get the potentially unnecessary early repair? Is it going to be an affluent child from an affluent family in Cherry Hills, or is it going to be a kid living in Commerce City with a lower socioeconomic status? Who's going to get that early umbilical hernia repair? For what it's worth, my hypothesis was the Cherry Hills family. So using a similar study design, the answer was a resounding yes. In the above forest plot, odds ratio point estimates to the right of the screen favor early repair. What we found in this multivariable analysis was that children with public insurance and lower income were significantly more likely to undergo early repair than their higher socioeconomic status peers. So it's the Commerce City family compared to the Cherry Hills family that's getting that early repair. You'll also notice that girls are more likely to undergo early repairs than boys. And to further highlight the above disparities, being publicly insured and in the lowest income quintile conferred an even higher 2.2-fold increased odds of undergoing early repair. To prove that children from these sociodemographic groups did not present to hospitals with higher rates of incarcerated disease, we repeated our analysis in the subgroup of children who underwent only emergent or urgent repairs and found no significant associations. Finally, we performed hospital-level analyses to assess whether a single hospital or group of hospitals accounted for the overall effects that we were observing. And to orient you to these forest plots, insurance data is on the left with income in the middle and gender on the right. Hospitals are now on the y-axis, and in each figure, almost every hospital has an odds ratio greater than 1, represented by the black line, and many hospitals have odds ratios greater than the overall effect for that predictor, as represented by the red line. So our study, unfortunately, wasn't powered to demonstrate significant effects at the hospital level, which is why the confidence intervals are so wide. But you can clearly see that the vast majority of hospitals likely contribute to the overall effect for each of our significant predictors. We therefore concluded that public insurance, i.e. Medicaid, lower income, and female sex were independently associated with early repair of asymptomatic umbilical hernia in children, and that the effects of low SCS surrogates appear to be additive. These findings prompted us to look into surgeon-level practice through a survey that we administered to the members of the American Pediatric Surgical Association. And we asked this question: how do pediatric surgeons think they manage children with asymptomatic umbilical hernias, and what clinical or non-clinical factors can influence them to operate on a child earlier than they normally would? And in the interest of time, I'll just show you this one figure from the paper, which demonstrates from top to bottom how different anatomic, caregiver, sociodemographic, and biological factors influence pediatric surgeons to offer elective repair for a young child with an asymptomatic umbilical hernia. And I apologize for the size of the font. I'm sure you can't read that, but overall, I'm just trying to highlight here that anatomic factors, which include a larger defect size, growth, or a proboscoid change, do in fact influence the majority of surgeons to operate earlier. That's the red and the orange you see over there. Caregiver factors such as anxiety over future incarceration risk, cosmetic appearance, and perceived parental neglect also influence many surgeons. However, the social demographic and biological factors have noticeably less influence. It should be noted that nearly 10% of surgeons said that they were influenced to operate earlier if the child was a girl or Black race, perhaps hinting at the disparities we identified in our previous study. So based largely on this body of work, the American Academy of Pediatrics, in collaboration with the American Board of Internal Medicine Foundation's Choosing Wisely campaign released updated consensus guidelines recommending against surgical referral of most children with asymptomatic umbilical hernias until 4 or 5 years of age. So remember Dr. Stanford's quote, how do we dispel subjective narratives with objective data? And I think we did it here with umbilical hernias. So I'll now pivot to one additional health disparity study led by your very own Dr. Yanis Ziogas, building on his extensive research career and passion for pediatric liver transplant patients. And this work was presented by Dr. Ziogas as an oral presentation during the first plenary session at our largest annual Pediatric Surgery Association meeting, which is a feat that very few, and certainly I was not able to accomplish as a research fellow. And then the work was published last year in the Journal of Pediatrics, which is one of our highest impact pediatrics journals. So a huge congratulations to Dr. Ziogas for this really important work. And his study question was simple yet elegant. Do disparities in surgical care exist amongst children with pediatric liver cancer? And for the trainees who haven't spent much time with us at Children's Hospital yet, hepatoblastoma and hepatocellular carcinoma are the two most common primary pediatric liver malignancies. And in one very overly simplified sentence, treatment is multidisciplinary and includes curative intent liver resection or liver transplantation with or without chemotherapy. I will not take further questions about the management of liver cancer other than the surgery. While surgery is necessary for cure, and that's the key here, it is necessary for cure. Recent studies from Dr. Ziogas have shown that 25% to 33% of children with hepatoblastoma or HCC in the US never get to surgery. So for this study, we used the National Cancer Database to perform a retrospective cohort study of 811 children with hepatoblastoma or hepatocellular carcinoma over the 10-year study period. And overall, similar to previous data, only 3/4 of patients underwent surgical treatment. We also found that patients who underwent surgical treatment were significantly more likely to be white, have private insurance, and reside further away from their treating cancer hospital. Patients who underwent surgical treatment were more likely to have fewer medical comorbidities, with this Charleston-Deyo score, smaller tumors, and non-metastatic disease at diagnosis. That all makes sense. Through multivariable mixed effects logistic regression, we then looked to identify the measures, the sociodemographic factors, and their influence on rates of surgical treatment after adjusting for disease-related factors and hospital-level effects. Subgroup analysis by tumor histology was also performed. And what you see here in the overall cohort, so these are all kids in the study, Black race, no insurance status, or again, having Medicaid insurance, were independently associated with decreased odds of undergoing surgical treatment after adjusting for all other covariates. And in only children with hepatoblastoma, Black race seems to be the driving predictor, with a 53% decreased odds of undergoing surgical treatment compared to white patients. It's just because of their race, just because of the color of their skin. For some reason, they're not getting to surgery. And in only children with hepatocellular carcinoma, children with no insurance or Medicaid insurance had a 90% decreased odds of undergoing surgical treatment compared to children with private insurance. So we concluded that Black race and having Medicaid or no insurance were independently associated with decreased odds of undergoing surgical treatment in children with hepatoblastoma or hepatocellular carcinoma. So to wrap up, I hope I've proven to you that all children do not receive equal surgical treatment. And it's important to recognize that providing equal care may not translate into equitable care for all. We should recognize that health disparities exist and that disparities in surgical care are prevalent across the specialties, whether it's at the Children's Hospital here, at the adult hospital. And pretending like they don't exist does not help any of our patients. Finally, supporting disparities research is necessary to guide advocacy efforts and defend against policy initiatives that will worsen health disparities for many patients, including children. And I've shown you multiple studies now that objectively demonstrate that having Medicaid insurance is an independent risk factor for worse health outcomes. So please answer me this. How will any of the under consideration $880 billion federal budget cuts improve the lives of the 80 million people in this country covered by Medicaid? And as a friendly reminder, almost 50% of those individuals are children. As surgeons, healthcare providers, and advocates, we are in a powerful position to fight the good fight. And I hope you all join me. Thank you for your time and happy to answer any questions.
Thank you very much. Compelling information presented very, very well, very clearly. Time for one question from anyone in the audience who would like to jump in. Dr. Yang.
Yeah, Heiko Yang. I'm assistant professor in urology. One question about, I thought the evidence that you presented in the case of the umbilical hernia repair, really compelling, that the vulnerable populations get more surgery. And then in the contrasting example, in hepatocellular carcinoma, they get less surgery. How would you comment on patient versus provider factors that might influence that difference in sort of disparity or outcome?
That's a great question, and I don't know the answer to that. I told you that our hypothesis was that it would be the privileged children who would get that unnecessary repair. So it's multifactorial, and I think it depends on the disease process and who the patients are and who the providers are and where you're practicing. So it's very complicated. But I think my point here is that we have to keep doing the work to identify which disparities exist within individual patient populations and their diseases. With the umbilical hernia, it's kind of a chip shot. It's an operation that most surgeons can do in about 20 minutes. It's very low risk. There are very minimal complications, and the kids do better and do great. A liver resection or a liver transplant obviously is a very different operation, but I would argue much more complicated, that requires much more multidisciplinary care. So I think that follows the more traditional line of thinking that the disadvantaged or vulnerable patient won't get there. It's just too hard to get there. With the umbilical hernia, it's quite a bit easier to get there. All you have to do is get to the surgeon. And so for that reason, our large governing bodies actually recommend against referral to the surgeon, protect the patients from the surgeon, which is an interesting concept. But in this case, actually, and I hopefully should prove that to you with the data, that if the patient got to the surgeon could be convinced by the parental anxiety or whatever the reason to fix the hernia. But it's complicated.
Good. Thank you.
Thank you very much. Great presentation. Thank you, Dr. Ripley, as well. We're adjourned. Enjoy the rest of your morning.